So, so we have a very interesting case. I think it will be of interest to neurologists also on how to treat intractable cancer pain by giving gamma knife to pituitary stalk. It's a very innovative procedure. And I have the pleasure of Dr. Who's going to present? President? Yes. Okay, Shiva will present and Dr. Deepak Agarwal will moderate.
Good afternoon. I'm Dr. R. Savakrishna from Senior Resident Department of Neurosurgery. Let us start with the clinical combined rounds for today. Gamma knife radiosurgery to the pituitary stalk, a breakthrough in cancer pain relief. I'll take you through the patient presentation, the interventions given, the outcome, and our basis of success. The patient is a 44-year-old lady who presented to AIIMS Palmo OPD on Jan 2024. She had shortness of breath, intermittent cough, holocranial headache, and recurrent seizures. She's a known case of type 2 diabetes and hypertension and hypothyroidism. On evaluation, chest X-ray, CECT, PET scan, and CEMRI brain was done. They were suggestive of right bronchial carcinoid with left anterior temporal lobe metastasis. Now, to tackle this, a team was formed. Department of Surgical Oncology, Department of Neurosurgery, and Department of Oncoanesthesia and Palliative Medicine. The first intervention, our plan was to deal with a metastatic lesion in the brain, and so the first gamma knife therapy was given to tackle and control brain metastasis. The target volume was 1.83 cc. It was a small metastatic lesion. Primary GKRS was given via Lexel coordinate frame G. 18 grain single sitting was given on 11th March 2024. 96.8% received dose greater or equal to 18 gray. Left optic nerve and chiasm shielding was done. This shows so 18 gray radiation was given at 84% isodose line. Now I'd like to call once we control the brain metastasis, it was time for surgical oncology. I'll call upon Dr. Chinmay from surgical oncology.
Good afternoon, everyone. So the patient was referred to us, and she already had a CT chest, which was suggestive of a posterior mediastinal mass of 3 centimeters with the peripherally enhancing calcified. It was a peripherally enhancing calcified lesion. And an EUS with FNA was done outside, which was suggestive of a round cell neoplasm favoring a paraganglioma. And biochemically, it was non-functional. She was referred to IRCH. We got a Dotanok PET in which there was a 3.4 by 3.4 centimeter lesion in the posterior segment of the right lower lobe with the coarse calcifications. And there was also a suspicious left temporal lobe lesion of 1.4 centimeter, which was suggestive of METs. An MRI brain was done, and it was found that the temporal lobe lesion was likely metastatic. So further bronchoscopy and endobronchial ultrasound was done. It is suggestive of a vascular lesion in the distal right intermediate bronchus extending up to the right lower lobe bronchus and enlarged right hilar lymph nodal mass. A biopsy was done from this lesion and it was found that was a carcinoid, which is not otherwise specified. The IHC was positive for promogranulin and synaptophysin. So we formed a plan. We got a final diagnosis of a right intermediate bronchus carcinoid with brain mets, and we planned to treat it with the curative intent. So the brain mets, as we've already mentioned, was managed with gamma knife and followed by the primary tumor, which was planned for a right lower bilobectomy. So the procedure was performed on 21st of March 2024 under GA with a double lumen tube in C2 in the left lateral position. We used the uniportal BATS approach. These are just representative images. We did not have images for this patient. And we did a right lower bilobectomy, removing the right middle and lower lobe, preserving the right upper lobe. Intraoperatively, we found a 5 by 5 centimeters hard mass originating in the right intermediate bronchus, which was involving the right lower lobe and right middle lobe, with a few subcranial lymph nodes, but there were no intrathoracic mets or effusion. During the post-op period, the patient was well. ICD was removed on post-op day 4, and the patient was discharged on day 5. The post-op histopath was suggestive of a typical carcinoid with a margin negative resection with a mitotic index of 1 per 2 millimeters square, a Ki67 of 2%. The visceral pleura was involved. The stage was T2 and 0. The patient was discharged, and she later developed pain. This part will be covered by Dr. Himanshu from the Department of Anesthesia and Palliative Medicine. Thank you, Dr. Chinmay. The patient was sent to us in April 2024. So, whenever the patient comes to the palliative care department or OPD, we evaluated the patient on the basis of biopsychosocial model, which include a concept of total pain, including the physical pain, emotional pain, social and spiritual pain. So, at the time of presentation, she was having a severe headache, which is 9 out of 10 on the numerical rating scale, characterized by throbbing and aching sensation, mainly localized to the temporal side of the right head. And she was also experiencing the general weakness, intermittent nausea and vomiting. As far as the psychological pain was concerned, she was on regular on medication. She was adjusting dose of the opioids by herself without consulting any of the healthcare professional, and she was experiencing inadequate pain relief, and this led to the anxiety and agitation, including the episodes of crying in the OPD due to the severe pain. As a social component, she used to live alone with her son and without any caregiver, and usually she used to show hesitancy regarding the long-term admissions, and she used to feel anger due to the insufficient headache relief. So, as a palliative care interventions, our first and foremost purpose was to alleviate the physical symptoms. So, the patient had multiple episodes of admissions in the palliative care unit, mainly for the headaches and once for the shortness of breath. So, during each admissions, IV morphine was titrated for headache, and each time she was restarted on medical decompression, which was previously advised by the neurosurgery team, which she has stopped by herself. So in April 2024, she was titrated and converted to 5 milligram of morphine every 4 hourly orally, along with the adjuvants, anti-epileptics, and the anti-edema medications, which was later increased to 30 milligram every 4 hourly orally after titration each time, with continued use of the adjuvants and the other drugs till December 24. And each time during the admission, she was advised to follow up in the neurosurgery outpatient department. She was later planned for repeated gamma knife radiosurgery for the pituitary stalk for the intractable pain. Along with the relief of the physical symptoms, she was counseled for taking the medications regularly and to visit the respective OPDs as scheduled during each visit. And emphasis was placed on monitoring and adjusting the medication regime regularly to ensure the effective pain management. Prognostication was done during each and every admissions because her pain was primarily attributed to the progression of the disease. So this was prognosticated during each admissions, and anticipated symptoms including the persistent headache, nausea and emotional distress, which will require ongoing management and support, was prognosticated. She was thoroughly given regular psychological support for coping of the emotional distress, which included multiple rounds of the counseling during each admissions to address her psychological and emotional needs. Finally, she was transferred. She was taken for the gamma knife surgery, which will be dealt with the doctorship.
Thank you, Dr. Himanshu. So we dealt with the lesion in the lung, we dealt with the lesion in the brain, we achieved good control, but what remained was an intractable pain. She's a single mother and a lawyer by profession, a criminal prosecutor. Her main issue was that she was on 30 milligram morphine 6 times a day. She was not able to perform at court, she was not able to take care of a child, and the time that she has left is filled with pain. So in all this, gamma knife pituitary radiation turns out to be the holy grail. So I'll take you through the GKRS planning and the mechanism and the literature. The GKRS planning, pituitary stalk radiation was planned. Our target was like a needle in a haystack, very small target. We need very good fiducials to achieve that. GKRS was given via Lexel coordinate frame G. 120 gray radiation in single city was given on 24 January 2025. 0.01 cc of our target receives dose equal or greater than 120 gray. Simultaneously, the critical structures, the organs at risk, brainstem, bilateral optic nerves, and optic chiasm were shielded. So this yellow dot in between, this is the pituitary stalk radiation. This is the radiation isodose lines which spread outwards. The bilateral optic nerves, optic chiasm, and the brainstem were shielded. So the outcome, the patient showed a miraculous recovery. Significant pain reduction as early as post-op day 3. Morphine was tapered to 20 mg every 12 hours from post-op day 3. At 1 week follow-up, her VAS score was 2 out of 10 and morphine was discontinued thereafter. At 6-month follow-up, sustained pain relief is there in 6-month follow-up. Patient is not currently on morphine. Her VAS score is 2 out of 10. She's on TAP PCM SOS. She has generalized weakness, and in the first month after gamma knife, she experienced certain side effects such as increased sleepiness, hypersomnolence, but that is expected in certain cases. Her hormone profile, she's already hypothyroid. She was on 150 micrograms of thyroxine. That was same as she was previously on since 2010. Her cortisol this month, this was done in September. Cortisol is slightly low, for which she is under follow-up in endocrinology. So I'll take you through the literature. So how does pituitary stalk irradiation or hypophysectomy affect pain? The thing is, there is no definite answer. Nobody knows, but we have several working hypotheses. So the historical evolution of it is, initially surgical hypophysectomy was targeted for hormone sensitive tumors to control the growth of hormone sensitive tumors, and in those cases pain relief was reported in patients. Slowly from surgical hypophysectomy, people moved towards chemical hypophysectomy using alcohol injection. Then now is the area of pituitary radiosurgery. So the mechanism of action, there is no definite mechanism of action established in literature. Targeting the pituitary stalk is hypothesized to involve modulation of neurochemical pathways. High dose irradiation to pituitary stalk likely triggers the release of endogenous opioids, including beta endorphins. These are demonstrated in the CSF samples of patients who receive pituitary stalk radiation or even in surgical hypophysectomy. These endorphins modulate the nociceptive pathways, providing rapid and sustained analgesic effects. So there are three main hypotheses of how this is supposed to work. Let it be surgical hypophysectomy, chemical hypophysectomy, or radiosurgery. So the three main mechanisms are, first is by tumor regression. The hormone dependent tumors usually shrink after pituitary radiation or surgery, which leads to effective in cancer pain. But this is not a good explanation because this won't lead to immediate pain relief. And even in non-hormone responsive tumors, pain relief has been reported. There is a role of increased beta endorphins. This is one of the leading hypotheses, but there are studies which have used naloxone to block this effect of beta endorphin to see whether the pain relief effect is still blocked. What was found is the early part of the pain relief might be blocked in certain studies, but in most of the studies they have shown that even when you give naloxone to block the endorphins, the pain relief is still sustained in this patient. So the third and one of the leading hypothesis now is hypothalamic neuroendocrine modulation. That this is not a destructive effect, but a stimulative and a neuromodulatory effect, which is the actual way through which the pituitary irradiation works. So why GKRS? So we have seen historically surgical or chemical hypophysectomy was employed for managing intractable cancer pain, but surgery comes with its risks. There were patients who had panhypopituitarism, diabetes insipidus, and visual dysfunction. So this is to compare surgical hypophyseectomy, neuroadenolysis, and radiosurgery. Initial pain relief. The most rapid pain relief out of the three is achieved by radiosurgery, and long term it is comparable with the surgical hypophyseectomy, but with none of these side effects or with very minimal side effects. So this is a review of all the this is a compilation of all the literature that has been available on pituitary stalk radiation. What we can see is in almost all of the case, initial efficacy is near close to 100%, and sustained release is 70%. There is one study which has low. There is one study which has reported excessive sleepiness, which we also have found in our patient, but that resolved after 1 to 2 months. So, what is new about it? The modern dose planning techniques, as demonstrated in this case, where you have to target a tiny target, so finding a needle in a haystack, and you have to protect the critical structures from radiation, that is optic nerve, chiasm, and brainstem. So GKRS offers a non-invasive alternative to traditional hypophyseectomy with a more favorable safety profile. Evidence from multi-center studies and case series support its efficacy in alleviating pain within days of treatment. As we've seen in our case, within 1 week she was off morphine with minimal complications compared to traditional hypophyseectomy. So our working hypothesis is the early part may be due to the beta endorphins, but the actual mechanism is by neuromodulation. So it is stimulation, not destruction. Literature and clinical experience both support this. There are studies with MR spectroscopy findings showing stimulating effect on the hypothalamus thalamus. The NAA by CR ratio, which is related to activity of neuronal cells, is remarkably increased after 24 hours of gamma knife pituitary radiation. So gamma knife pituitary radiation might have a stimulating effect on hypothalamus thalamus instead of expected destructive or ablative effect. So there should be some neuromodulating effect, which is the actual cause or the actual mechanism how it works. So what the future beholds? Broader implications of this modality extend beyond cancer-related pain in post-stroke thalamic pain syndromes, where similar mechanisms may be leveraged for pain relief. So this is a fresh area for research. The future direction of research should include exploring the long-term efficacy of GKRS in managing cancer-related pain, identifying the biomarkers to predict the patient response, and optimizing dosimetric parameters to enhance outcomes. I call upon Professor Deepak Agarwal, sir.
So thank you, Dr. Shiva. I think this case highlights how different modalities can cause pain relief. This patient was on 120 milligram of morphine per day for many months, which came down to zero within a week or a month of start giving this drug. So in any pain, which could be any pain anywhere in the body, when it becomes intractable and we can consider, obviously there you have to consider the long term effects, and that's why the cancer pain is the most amenable, because these patients have a finite lifespan after the diagnosis of cancer. And any question, I'm happy to answer. Yes, sir. There are no studies on repeating, but definitely we can repeat it. We have for trigeminal neuralgia, we are repeating 3 times, 4 times on the same nerve. So I think for this also. The second is the efficacy. As per the studies, it lasts till the time of the death of the patient. So some patients who die 1 year, 2 years, also this efficacy is lasting. But there are no studies on benign cause of the pain, where the life expectancy could be normal. So we don't have that data. So everybody is really worried if we give it like for low back pain, severe low back pain or failed back syndrome. Nobody has tried. So again, it can be where everything else has failed. Maybe we can try in those patients. So this is the first. This is, and we want to educate the. The palliative care people can also see the results. That was one of the goals of this CCR also.
It's so heterogeneous, cancer pain.
Yes.
Why is it that at one point it's giving it?
That nobody knows, but I think finally the pain, the realization of pain or the feeling of pain, it somehow affects that. Because we were also surprised that it takes effects almost immediately. And previously, we were very scared that this patient might be a kind of anxious personality who, because she appears normal in the OPD, so we didn't know if she's having pain or not, but she's on 120 milligram. But as of now, she has stopped for last 6 months.
I remember right, you said it was just discovered by chance when they were doing a vasectomy for
Yes.
some other reason
Yes.
they found there was pain.
Yes.
This is of the really important medical breakthroughs are
Surrender.
One of the hypotheses for this is that pituitary controls a lot, many more hormones than what we actually know. So we only know a fraction of those hormones. A lot of these hormones could be involved in the pain mechanism. It's like the master gland. So once you obliterate the master gland, somewhere it's
So what were the other effects? So since pituitary is the master gland and there will be lot of hormones which actually are controlled by
Correct.
so there will be other implications in the hormones.
Yes. So again, very relevant question. Again, all these studies, because we have just one patient, but the studies, they have said there has been no hormonal dysfunction till the time patient was alive. So that's another thing. But these are limited studies lasting maximum of 2 years or so.
Maybe we need to do a bigger trial, maybe 30 patients each to at least to begin with.
Yes, but we, with great difficulty, we got one patient.
Yeah, but actually patient to all because
We'll be more than happy.
happy.
Yes, yes, we can.
With conventional neuro disease versus radio surgery to celiac access. Because it is very non-invasive and the effects are similar and side effects are minimal, so it is worth doing and why not you should do it.
Absolutely.
And we have all the possibilities, all interspecialties are there. So it is high time. And one more comment sir, regarding the effect on anesthesia, because lot of component is emotional component to pain. And pituitary and thalamus, we know they have a lot of control on the affect part of body. So the perception to anything, but they might be directly affecting that as well.
It might be. That's also a very relevant thing. This patient was, before that gamma knife for the pituitary stalk, this patient was sleeping 1 hour a day only. And that she came with that complaint that she's having so much insomnia, she's not able to sleep because of the
In
pain.
fact, it was very erratic behavior from there when
Yes.
to come to cry and
Yes,
house like
yes.
anything. So,
Emotionally labile, insomniac. So after that procedure we did, she was sleeping 20 hours a day for the next 15 days to a month.
so maybe they just leave that so that pain is taken care of.
Ah. So the family came to us that she's not waking up, she's just waking up to eat and then she goes back to sleep. Around 15 days to a month it lasted, then it became normal.
I hope you don't do it for insomnia.
So that is the common thing we also face. So patient is in pain and we relieve pain with auto mortality. They have good sleep for say 7-10 days depending on the sleep that they have introduced and after that it is normalized. So that is the normal thing and this really shows that patient really had sleep was really good. Otherwise they will not sleep.
They don't sleep.
spiritual by emotional, very slight combination.